Good evening, everyone. Welcome to Goodness Growth Holdings' third masterclass, Cannabis Use in Patients with Cancer. I'm going to give a minute here just to let a few more people roll in. Very excited to discuss this topic tonight. I want to remind everyone there's a Q&A tab. Be sure to submit any questions that if we have time at the end, we certainly will be fielding. We got a lot to cover tonight, so we'll be starting shortly. But again, just give it a minute or two before I introduce our speaker. Thank you for coming. Great. Good evening, everyone. We're going to go ahead and get started. We got a lot to cover tonight. I'm Dr. Stephen Dahmer. I'm the Chief Medical Officer of Goodness Growth Holdings. We're happy to present our third masterclass, Cannabis Use in Patients with Cancer, with Dr. Dylan Zylla. Dr. Zylla is a hematologist oncologist working to answer key questions in clinical oncology, improve pain and symptom management among patients with cancer, integrates research into his clinical practice and with protected research time and access to an institution with a strong reputation in quantitative, qualitative, and clinical research. Dr. Zylla is site principal investigator on multiple industry-sponsored oncology clinical trials. His projects focus on cancer pain, the mu-opioid receptor, and novel ways to treat pain. He was a key member of the Minnesota Community's Measurements work group that developed quality measures for cancer symptom control using patient-reported outcomes. And he collaborates with national leaders on integrating electronic PROs into cancer care. Since 2016, Dr. Zylla has spearheaded large-scale efforts to address how cannabis impacts the lives of patients with cancer. He led the Cannabis in Cancer CAN-CAN study, which randomized patients with metastatic cancers to receive early versus delayed cannabis to treat symptoms. In 2018, he published a survey of medical oncology professionals in Minnesota and demonstrated most clinicians support cannabis use for their patients. And in collaboration with the Minnesota Department of Health, he analyzed surveys of over 1,000 patients with cancer certified in the state's cannabis program since 2015. And they found that those patients experienced a significant clinical improvement in a variety of symptoms and reported few serious adverse events. As a medical oncologist and hematologist, he values the relationships he has developed with patients who have cancer or blood disorders. And I looked back, Dylan, and we've known each other for over 6 years. And it just is such an honor and a pleasure to introduce you. We've worked together on a very challenging area of research in cannabis and excited to get started with so much that you have to share with the group here tonight.
Well, great. Thank you, Stephen, for that wonderful introduction. And yes, it's been a pleasure working with Dr. Dahmer. He has really connected me to a number of thought leaders and research experts across the country as I started into this field. So it's been great, and was happy to do this talk tonight. So I have a lot of slides. I'm going to go through them kind of quickly and kind of save some time for question and answer at the end. So. Sure, here we go. No conflicts. This is what I hope to cover. Just a broad overview, a little bit of symptoms, a little bit about the questions of can it cure cancer, safety. Most of what I want to talk about is sort of what we're doing on the research and education side, and then again, some question and answer time. So when I was kind of getting into this field, one of the things I did is I wrote a review article on this topic, and much of what I'm going to present sort of comes out of that. This is a free text article, or free full text article you can get there. And one of the things we put together was this sort of figure about a scenario. So patients come to see me as an oncologist, and they ask me the question is, what do I think about cannabis? Well, there's naturally a number of questions that come from that. Is it available to them? What products are available? How are the different products out there? Will it help? What is the data that shows where there's a benefit? Is it safe? Those are kind of the key things that I think patients want to know from us. And then we obviously work together to make a decision on if it's right. So we try to answer all these questions in the paper, and I'll just put a couple slides together about the availability. And a lot of you have seen this kind of figure, just sort of the green wave. There's a multiple states that are now going with cannabis laws. The green has medical cannabis. The red has adult recreational use as well. And really, other than a handful of holdout states, most states are going to some type of cannabis product. I practice only in Minnesota, so some of the data I'm going to talk about is our Minnesota program. This is our program, which launched in 2015. And you can see there was a kind of a slow uptick, and then eventually more and more and more patients got involved, I think, as acceptance grew to some degree. There were two big reasons that those spikes happened. Most of them were indications that were added to the state's program. So intractable pain was added in 2016, and then they changed it to chronic pain. And that really, I think, has been the driver now of what patients get into the program for. In terms of cancer, since that's my focused area, this was last year's data, but in 2020, of the patients that were certified in the state program, about 7% had a cancer indication. I thought that was kind of low. You can see pain is, of course, the leading cause at the top. And of those 7%, they kind of broke things down a little bit. Here we're by age breakdown. You can see we, compared to the other indications, are a much older population, not surprisingly with cancer patients. About 37% of our patients are 65 years or older, a lot more are 50 or older. So definitely not a younger skewing crowd, which I think is important for tolerability and dosing and things like that. This is a very nice study. Some of you may be familiar with the Pergam study published in 2017, probably the best survey study about cannabis use in the cancer population. Broke it down kind of in those bold numbers there. Use is prevalent. Patients are using cannabis. Some may tell us that, some may not, but you can see probably about 1 in 4 on average patients are using cannabis at some point. So how do they become eligible? Again, in the Minnesota program, at least I know it's different in all different states, but they must meet with a clinician to certify that they have a cancer condition that meets that criteria. In Minnesota, they have to have severe chronic pain, nausea or severe vomiting, or severe muscle or weight loss. Most patients can get there, especially with the advanced cancers who are going through treatment, but not everybody necessarily. They have to be a Minnesota resident. Our program requires a $200 fee and then a yearly recertification. Back to the Pergam article for a minute. And again, what we see and what we have seen even in our own practice is that patients with cancer, they want education about it. They don't necessarily want to use it necessarily, but they want to at least be notified about it. And they're really looking to us, their care team, their oncology team, to give that information. You can see on the slide or the graph on the left, almost 2/3 of patients are interested, moderate or high interest in having more information about cannabis. So that's pretty striking, I thought. What products are available? This is a little bit harder nut to crack just because there's so many different things out there. Again, in this review paper I wrote, I put together this figure, which I still kind of look at and trying to figure out. On the left, are we dealing with prescription type cannabis medications, extraction medications, which I know a lot of the state programs, and Stephen with Vireo and all of those products are essentially extraction products, versus whole plant products. I take that back. Now I know whole plant is coming to Minnesota. So now some of the Vireo products are whole plant products too. We, for a long time, up until a month ago, did not have whole plant products in our state program. And then you can see on the top, is it a THC dominant balanced or CBD dominant? Obviously, Epidiolex is the one on the CBD dominant side that's been approved at FDA. Most of the others are drugs that not many of us use: Marinol, Casamint, Nabilone, and then nabiximols, which we actually have some experience with. We were participated in that study that was done in the United States a number of years ago, and I can touch on later if anybody wants. So that's kind of the breakdown. And again, it's kind of hard to explain this all to patients. There's all sorts of different products. There's all sorts of different routes you can use. Cost, I kind of threw in there rough estimates, but that's kind of how the lay of the land is, at least in Minnesota. I might skip this other than to know, again, which I think everybody does, products are not covered by insurance. We've seen reports say that most of the patients using cannabis for cancer use are probably spending close to $250 a month or more, which is not cheap. And there I did say 2022 flowers, buds, and whole plants are become available. I actually just talked to my first patient who said they just got some here in Minnesota. So will cannabis help? There's actually a number of studies. And again, in our report, we kind of pulled all the main clinical trials. You can see some of these are double-blind randomized clinical trials. Some of them are more observational studies or open label studies. But in the cancer space, there have been a number of studies. In fact, since 2000, there's been, I guess I would say, more than 23 studies. At the time of this paper, there were 23, 10 of which were randomized controlled studies. We actually snuck in on the last part of that one. I did a state's analysis of the Minnesota program. That's this Anderson study. And I'm going to touch on that next, because basically what I did is I worked with our Department of Health, and we looked at the data of about, I think it was 1,100 patients at the time who were in the state program. And we looked at how did their symptoms change over time. In our program, every time a patient makes a new purchase, they're required to fill out a symptom survey, and I believe an adverse effect survey. And so we can get that data, and we got that data from the state. What this is showing you is over the first 4 months, what patients' degree of change is in various symptoms. So pain, nausea, and appetite were the three that they could be certified for. There actually was a number of other symptoms they reported that we have the data for, but you can see that their improvement was quite notable, right? So blue bars, high level scores, that's at baseline. So high level scores at baseline, 8s, 9s, 10s sometimes, that gets shifted over to the red, bars further on the left. So 0s, 1s, 2s. It didn't take pain and nausea necessarily completely away in most cases, but it certainly seemed to improve quality of life in these patients who were using. Now, there's some inherent bias in here, right? So we only had data on patients who continued to purchase, because that's how we got those 3 and 4 and 5 month data points. So we did go back and we said, okay, well, what if we take the denominator being anybody who made a purchase at least once and looked over the first 4 months and had some type of reduction, not just some type of reduction, but a 30% improvement or more in that first 4 months. So that will account for that sort of dropout bias of patients not purchasing again. And even there, when you look at this whole list of symptoms, we're seeing 30, 40% improvement of what I would consider clinically meaningful improvement over that time. There's another study kind of similar to ours that was done, a very large study, I think 3,000 patients from Israel, kind of showed similar things, pre and post. They used 6 months in their study. You can see how things kind of shifted as patients used more and more. What I liked about their study, which we weren't able to do, is they looked at other medications and what you could stop potentially. Things like opioids, right? There's a lot of data out there, I think, especially in the non-cancer population, about the potential to have cannabis improve your opioid use or reduce it or maybe even omit it. And you can see that this is what they reported there. It's pretty striking in this population. So I'm going to switch gears next, and again, kind of plugging our own horn here. This is the Cannabis Trial that Stephen and I collaborated on. This was just published last year. It was many years in the making and design and implementation and then analysis, but this is kind of what we did. And I want to just really jump to the heart of what did we try to do? What were we really trying to focus on? We were really trying to focus on, could we feasibly do a randomized interventional trial using a state-sponsored program? there are so many challenges to doing interventional cannabis work with INDs and FDA and DEA approvals and all this kind of stuff that we just said, what if we just use the state's program and kind of structure things in a way to look at safety and efficacy and things and use the products that were in the program. And so we looked at some other outcomes, of course, as well, but really this was a very small pilot study. This is the design. So we took patients with advanced cancer. They had to require opioids. That was our default to say, yep, you have severe pain. We had 30 total patients that were randomized. And interestingly, and I think the best part probably is that all of the cannabis was provided. So there was no limit into what patients could choose, which products they could use, how many different products they could use. It was really, let's get them to what works best for them and go from there. So we randomized patients to either an early group or a delayed group. The delayed group sort of served as our control group when we looked at 3-month metrics and some of the outcomes. We tried to capture medication logs, did some symptom surveys, did some end of study surveys, things like that. And you can see that's what we did here. This was our, I guess I would call it a guide. It wasn't necessarily a hard and fast protocol, but kind of our titration guide that both cannabis companies, we actually worked with both the different companies in the state of Minnesota, and both of their pharmacy teams use this as kind of their rough guide. I might skip over this. This is our enrollment. There were challenges. Of course, there was dropout. There were people that died. These are advanced cancer patients who some of were, end up going to hospice sooner. So our data and our analysis of those 30 patients, we really were limited to only 9 in each group, which is, of course, very, very small numbers. But I think this number is actually kind of the most telling. So there were 148 patients that we screened who met our eligibility criteria and who would have been, or actually were invited to participate, 30 of whom actually came into the study. That's a 36%, eligibility sort of accrual rate. In most clinical trials, you're lucky if you get 5%. And so I think this kind of shows that there is interest in this patient population. I guess the idea of getting free cannabis for 3 months was kind of intriguing to them. So anyway, I think this is something that there is high interest in. We actually thought we'd get better interest. Our goal was to get 50 patients in 6 months. That was our feasibility aim. We didn't reach that. Obviously, there were some reasons for that too. But that's kind of what we found. This is a kind of a messy slide, but the point being is that there were a lot of different products used. There were multiple different routes used. The average THC per patient per month was usually about twice as much as the CBD. So you can see 34 milligrams of THC. And that's average per day. Versus 16 milligrams. That's actually looked at here. So the THC versus CBD kind of estimates in terms of use. And then we did have one data slide, and again, it's hard to with such small numbers sort of make much of this, but we looked at 2 kind of pain and opioid metrics. The first was, did they meet their what we call a personalized pain goal? And you can see in patients who used the cannabis versus the quote standard of care, there were a few more patients that went up, not went down in terms of meeting their goals. And again, opioid use, which is, I think, a very good surrogate for their degree of pain. It actually stayed stable in the early cannabis group. It nearly doubled in the delayed cannabis organ control group over those first 3 months. So some other metrics didn't change a whole lot, but again, small numbers. Again, just briefly, some of the safety satisfaction things that we talked about. Patients really had very good things to say about their experience with cannabis. There were no ER visits. It was safe. There was not very much negative impact, either reported by the patients or the oncologist. And most felt it had some degree of benefit. And I think the last bullet there, may be the most important, right? So 44% of patients who ended up using cannabis at some point, either early or delayed, ended up going on to purchase cannabis through the state program on their own. But again, some just said, I might, but the cost was the biggest barrier, which we'll touch on later. So our conclusions of that study was that it is feasible to complete a pilot randomized controlled trial in state programs. They could be used in larger, more prospective studies. This was the average use we talked about, can potentially help with pain goals and opioid requirements, and generally well tolerated. So that was just one of our studies. Again, there have been other studies and some that are bigger studies. Obviously, the nabiximols data and the studies were placebo-controlled type trials. I have comments about those because I was a PI in one of those studies, and it was a really hard study to try to find the patient that fit the mold the best for that study. So some of those negative studies, I think, had their own issues. I'm going to touch base briefly on this question because it comes up not infrequently, is the question of, can cannabis treat or cure the cancer? Well, that other Pergam study, as I mentioned, they said that about 1 in 4 patients believe that cannabis was helping to treat their cancer. There are multiple books and case reports and online, groups. People know about Rick Simpson's oil probably a little bit. There was a Netflix documentary that talked all about this. Books out there, so it's out there. The problem is there's not much data in terms of the scientific literature to support that. There's a couple of studies on GBM. Actually, one that I don't have in here, I just came across, which we can touch on another time. I'll try to update my slides, but GBM has some data. There are some okay case reports out there. Here's an example of one I thought was kind of intriguing and believable. With lung cancer, somebody taking a not very big dose of CBD. And so we actually went ahead and looked at all of these claims. And I published this paper, I think this got published late last year, early this year, in Cancer and Cannabinoid Research, where we actually looked at all of the claims that we could find, all the articles, peer-reviewed journal articles that we could find, and tried to summarize that in terms of the claims that were made. And what we came up with was this. There were 77 case reports that we could find documented in the medical literature. They spanned a variety of cancer types. Most of them used only CBD, some in very, very high doses, though. You can see 800 milligrams a day. Most of the ones that used THC was pretty minimal in terms of the dosing. The biggest issue, of course, was there wasn't any substantiating evidence. And when it was reported, it was often non-validated things like circulating tumor cells and other things that were surrogate measures. So it basically, a lot of it is being talked about, but there really isn't a lot of data to sort of suggest that, outside of the preclinical and some animal model data, which I think is where a lot of this gets derived from. So we kind of went another way around trying to get at this. We kind of wanted to do our own case series. And so we put together this questionnaire that has been distributed internationally. Actually, we put it out to all sorts of cannabis specific face group pages, social media. I think Stephen and Vireo was kind enough to get it out to their email list. So there's actually a fair number of New York respondents, people who are using cannabis. And anyway, we asked a number of questions in there. This is a brief summary of who it went out to. It went out to about 1,000 patients, I think, opened the survey and answered some questions, 700 of whom did have a cancer diagnosis. And you can see some of their responses to those questions about does it treat their cancer? Does it cure their cancer? And you can see, again, about 30% believe that cannabis has helped to treat their cancer. We put this poster together for a conference at the International Cannabis Research Society annual meeting. I think this was in 2021. Yes, this was last year. So you can see some data there. It just kind of summarizes a little bit more about more of what these patients were telling us in terms of their use and what kind of things they used. I won't belabor that. So now, transition a little bit about what are we doing now? What are we doing in our research center, and what do I have going on kind of now or in the future? Well, there's actually a number of things, and I maybe for sake of time won't go into too much detail. I talked about the Cannabis Trial, that's done. I talked about the review article, that's done. I'm going to talk in just a minute about what I call a Cannabis Clinic. We call it our CanCare Clinic, and a registry that's been created for that. That was done last year. We are in the process of analyzing and finishing a very interesting study with the University of Minnesota. We were one of, I think, 12 cancer centers funded by the NCI to study cannabis use patterns. And we've done a number of large surveys with that and are starting to get some data. I unfortunately don't have that data to share with you today, but it's coming. We have an abstract at ASCO this year that's going to be touching on some of our initial data. I have another study which is nearing the point of getting activated, and that is using a topical cannabis cream. One is a high-dose CBD cream, one is a high-dose THC cream to treat women who have aromatase inhibitor joint pain. It's a very common condition that we see in our women with breast cancer, and that's about to launch, we hope, really momentarily. The other study idea that was kind of run into a little bit of issues is a protocol for using high-dose CBD to treat patients with refractory glioblastoma. Basically some IND issues and some other things that we're trying to work through, but we are still looking to try to get that going. And then some more of that anti-cancer case series project that is the data that we got. We're kind of rolling into our second phase with that. And then some things that are kind of on the horizon. Actually, the second project there is basically the second part of our cannabis trial, which I just presented. We are very close to getting funding for doing that same design, but using a cohort of newly diagnosed pancreas cancer patients, stage 4 pancreas cancer patients. I think we're going to get funding, and if we get funding, we think that study could launch as early as September, and we're really excited about what that could bring and the way it's been designed with some really good thought leaders. So those are some things, more maybe some CBD things, the registry, which I'll talk in just a second. Let's talk briefly about the Cannabis Clinic, and then I'm almost done. Not a couple years ago, late 2020, I started to realize, I kind of knew what I was talking about with cannabis. I kind of started to get some familiarity with dosing and treating patients. And then around in that time, I started having a couple patients reach out to me, actually from outside of my organization. And they said, we heard about what you're doing. We want more education about cannabis. We thought you'd be a good person to talk to. I said, oh, okay. Sound kind of interesting. And it was kind of a really great conversation. So it got me thinking, like, how many more people are out there, that would want this education? And going back to the Pergam study, well, 70% of our cancer patients want more education. So that's kind of a lot of people out there that that might want information. So I put together a clinic that I call the Cannabis and Cancer Research and Education Clinic. It's really focused on patients with cancer, again, who want to learn more. Some of them, like the patients who reach out to me, were using cannabis, but they didn't really know, nobody really guided them on it. They didn't really know what dosing and things like that. So we kind of go through a personalized education session, as you can see, touching on some of the things there. And this is just kind of hot off the press. So we looked, it's been open, the clinic officially has been open for about a year, and we've seen just over 100 patients in that first 12 months. This is kind of the breakdown of them. Most of them are advanced stage, palliative intent chemotherapy, not surprisingly, probably lots of symptoms. And most of them had a fabulous interaction with us and would recommend our clinic. We surveyed people a short time ago, and most were very, very positive about their experience with us. This is just some of the the information documents, again, things that we cover in the in the visit. I'll explain the visit just for a minute. This is a one-on-one virtual visit, so video visit with either myself, although I don't do as many of the consultations anymore, or with my nurse practitioner, who's a nurse practitioner trained in, who's really passionate about symptom management. And she's just great. And she's really done the majority of these consultations now. This is actually something we have billed to insurance because we look at it as like a symptom management clinical visit. So it's a follow-up visit, but it's just with the focus on cannabis instead of opioids and nausea meds and all the other stuff. So that's kind of how the clinic operates. I left a few last slides just from resources that I really like. The NCI website, I think, is really good for patients, but also for providers. It's really, really comprehensive and has really nice links. I actually just looked at it before this meeting, and I was thrilled thrilled to see that our cannabis trial that we just published earlier this year is now on their website. So we made it, Stephen. NCI likes our stuff. So the Department of Health website for those who want to know more about our state program. The National Academy of Science, Engineering, Medicine put this book out. I think that's now 2017, 2018, but you can actually get a free PDF copy at that link there. And then I put, again, my review article link there. I don't know. I think those are probably some of the better ones. There's some good textbooks out there too. Dr. Sulak, who I referenced just a minute ago, he's been a real asset and somebody I've been connecting with a little bit more too on the clinical side of things. He just wrote a nice textbook last year that I really like, and others. Lastly, I kind of put this as one of my takeaway slides. I think the research has to continue. We have to connect. We have to connect with each other. We have to collaborate. That's, again, what Stephen and I have done, I think, quite a lot. Spreading the word of our work. I kind of use this as sort of one of those avenues to do that. We certainly need contributions. Philanthropic donations helped us get a lot of our early studies going. And as those of you who are in this field know, it's really hard to get funding for cannabis or for cannabis research. So I think we're still in need of finding ways to do that. I put my research bio link on there if you want to learn more about me or some of the work I'm doing. It has my CV, all my publications and different things you can look at there too. So I think that's all I have. I tried to, half hour, there we go. So have ample time hopefully for some question and answer, but thanks for the time.
Thanks for that, Dylan. Fantastic. And just, the amount of work behind the scenes to get to that point, so much that was shared there. There was a question from a research student at UNLV, and maybe if you go back one slide, I think that email might be the best way to kind of reach out to your team, for potential collaborations or others, just to answer that question that came out. Just so much good information there, and just, amazing to see how far that you've come, Dr. Zylla, and even the projects that are still planned. Before we jump into question and answer, and I do encourage everyone, if you have a question, please put that in the question and answer. We'll be looking closely at those. We have a couple questions here teed up. If you did enjoy this content, again, this is our third masterclass, and we are very excited to announce that we will be offering free CME for an event that's coming up, Spring into Cannabis. It's really just a chock full. Unfortunately, Dr. Zylla has some much deserved PTO, so won't be there, but chock full of some great lectures as well. I just put a link into the chat here into that upcoming CME event, which will take place in Minnesota, but there is planned for virtual attendance as well. We encourage everyone to participate. And again, encourage you to put some questions in the chat here. And Dr. Zylla, maybe we'll just jump right into it. Dating back 6 years ago, it took a lot for an oncologist, a physician, to get interested in cannabis and medical cannabis. What piqued your interest back in the day?
Good question. I'm not on mute. I think the interest in this field, and I guess my field, I would say more is symptom management, kind of probably went back into my oncology fellowship days. It was really sad to work on the hospital wards where most of our training took place and see patients admitted left and right for just intractable pain and nausea and multiple symptoms. And, we had opioids and we threw lots of opioids at them, but that didn't always help and, and certainly had their own complications. And so seeing that, and that kind of another tangential issue is my early work in this field was really on opioid use. And I had some data that kind of suggests that opioids have a negative association with survival. The more opioids you use, the worse your survival is. That might be certainly just because their cancer pain was bad, but there's also some preliminary data, some intriguing data, I think, about the way the opioids trigger through the mu opioid receptor and actually can lead to a number of cancer progression signaling changes. And so the question is are opioids bad if they're fueling the fire, right? If they're triggering and actually causing more cancer growth? And so when the cannabis law was passed in 2015, I was still kind of doing some of that work. I still am doing some of that work. And I said, well, geez, if that's the case, at some point, we're going to have to figure out something to treat their pain with that's not opioids, and what would that be? And lo and behold, cannabis was out there. And so that's kind of what piqued my interest initially, and started to connect with some of the people in my organization. And I think both of the cannabis companies I got involved with, started to work with the Department of Health. And that's what led to our initial work group that I think Stephen's been part of for now 6+ years. And it's just been a great group. We all have this passion to figure out a way to learn more about cannabis and study cannabis. And, that's what led to our essentially our trial that we just talked about.
Great, and maybe piggybacking off that a little bit, again, there's one thing to, at least to be open to medical cannabis, but then it's another step to move forward and try to work your way through the hurdles of researching medical cannabis. What led to even that second step, to dedicate the time and energy and everything to research this plant?
Well, again, I mean, I feel like our patients deserve it. I think they, face so many obstacles and challenges. Cancer is a horrible disease, and advanced, stage 4 cancer. Obviously, we're looking for comfort. We're looking for quality of life. We're looking to extend their life when we can, but quality of life is really the main thing. And I think that is a big reason that I thought cannabis was a potential way to do that. The problem is, and I think it's becoming better, but I think the problem is that, patients were a little hesitant. Providers initially in Minnesota were kind of hands off, don't want to know anything about it, don't want to touch it. That's changing, thankfully. But, I think we needed data. We needed to at least know that there was data out there. We oncologists were a little, stubborn. We're used to really good phase 3 double-blind trials that show a 2-week survival benefit, right? So we want data, but there's not that degree of data in a product that's out there like this. And I think that's going to forever be the problem, is that robust randomized clinical trials are going to be very challenging. And already there's widespread use, and there's so many products on the market. And how do you actually study a plant-based product like this is challenging. So, why research it now? I mean, going forward, I think we owe it to our patients. I think we owe it to our providers, and we probably are going to owe it to our policymakers. I hope, obviously from the schedule and descheduling of cannabis, that happens. I think that's going to make a huge impact on research. And I think we need data, hopefully, so that we can eventually get some support to say, hey, this should be something that insurance companies should pay for, because we'll maybe touch on costs later, but I think that's going to be a challenge for widespread use, even if there's data to support it, is the cost.
Absolutely. 2 good questions that came through. Very fresh in Minnesota is the addition of flower. But what thoughts do you have on future research projects utilizing flower, as opposed to what kind of what we've done in the past, or the extracted products?
Yeah, that's a good question. I'm not sure at this point. What I do like about the extraction products is that you can define dosing, and at least it's something to hang your hat on in terms of saying, okay, well, at least they used all these different products, vapes, this, that, but you can come back and say their THC dose was this, their CBD dose was this. And I understand there's all sorts of other things the plant has, and terpenes and profiles and things that may be as important as the CBD and THC dose, but at least it's something. I think flower will be interesting, obviously, for the sake of the fact that it's going to be a lot cheaper. That's my understanding, is it could be 50% cheaper than some of the extraction products that our patients can access. So, of course, patients are going to want to use that. And we're going to have to figure out how to do that. I don't know. I don't have a lot of ideas quite yet about how to study flower. Stephen and I have talked a little bit about maybe partnering with some companies who, I think there are ways that you can actually maybe monitor or track the actual THC components, and if you actually smoke it. That would be interesting, just those pilot kind of studies. But I don't know. I think there will be some hesitancy too, though, because at least our patients who, let's say, come into their chemo infusion chairs or something, they may want to use cannabis in our clinics, which they do kind of do at this point. Not going to be able to do it if you have to smoke it. What about those patients that get hospitalized with pain? I have a number of patients who are in the hospital, and they have their little lockbox next to them with their cannabis, that they're approved to get. They're not going to be able to smoke it with their oxygen on next door, stuff. So I don't know. I'm not sure where we're going with whole plant.
Yeah, I do. I think we've talked about it a little bit too. Certainly see the technology moving forward to better measure even dosing, vaporization of whole flower. And I think there certainly will be a role in the future. This is a good one that came through here from Paula as well. What do you see as the value of real world evidence, registry data? Some people in the space believe that it may replace RCT data eventually. So kind of the dichotomy there between the real world evidence and the RCT. What are your thoughts on that, Dr. Zylla?
Well, again, I mean, I think there can be power in that data. One of the things I didn't really touch on, but we're doing with this Cannabis Clinic that I've created is creating a registry. So again, 100 patients isn't a lot, but it's a start, and I hope to expand it. And I'd be welcome and open to talking about patients who were, anybody out there who's interested in maybe collaborating or looking at, using something similar as they're tracking their own patients. So how our registry works. We built in REDCap. It's a very simple database, essentially. And it's kind of neat because when patients get, scheduled for their visit with their cannabis provider or the cannabis clinician, they get automatically sent a survey that asks them about their cancer, their pain medicines, their cannabis history, what cannabis products they're using, if they are using, what their symptoms are, kind of a nice little survey, an intake survey, we call it. And we use that. And it's really helpful to then provide those consultations because we know exactly what they want to cover. They know exactly what they've used, what they've not used. And that's great data too. So we have that data. Then we have our visit and we collect a little bit more data and we talk to them, and we actually then in the database kind of say, this is the product we use, this is the amount of THC I want you to use, this and that and the other thing. And then of course there's a follow-up portion, a follow-up survey that is just getting activated. So I don't have much data from it yet, but we finally figured that out, and it's going to be a 2, 4, 8, and 12 weeks post their initial intake visit, where they'll be sent quick questions about what products are you using for cannabis, how have your other medications changed, what symptoms are improving or not improving, and then of course any side effects. So I think that's that kind of real data use that, whether it's going to be practice changing, I don't know, but it's certainly hypothesis driving and helping us with potential future clinical trials. I do think though that we still probably need some type of interventional studies to really change minds of some people. But maybe the big data will help us get there in one area. I actually just realized I did not put in some slides. I don't know. I think I must have accidentally deleted those about risks. There are some concerns and risks that I have, or concerns I have about risks of cannabis. And, I think overall cannabis is a pretty safe product. I kind of attribute it to a safer product than alcohol sometimes when I'm talking to patients, and it actually helps do something rather than alcohol, which I guess it does some things. But in terms of safety, I think it's a pretty safe product. Where I do have concerns as an oncologist is the potential for interaction with our chemotherapy agents. And mostly, I'm not really talking about standard like IV chemotherapy. That's been around forever, and we kind of know people do pretty well. Although there are, very narrow, what we call therapeutic windows and indexes for using those agents. The big two issues are immunotherapy. So those who may not be familiar with that, immunotherapy it is a game changer. It's changing the way we practice oncology in many, not all, but many cancers. There is some retrospective data. It's not robust, but it's there, and it's pretty compelling that says if you're a cannabis user on immunotherapy, your outcomes may be worse. Your tumor is not going to respond as well, and there's some data now saying your survival may be worse. And that makes sense to me. If cannabis is an anti-inflammatory sort of drug and it dampens down your immune system, that's the exact opposite of what we're trying to do with immunotherapy, which is to boost your immune system, go fight and find the cancer. So things like that, I think the real world data sets can help us with, and maybe the only way to do that. We're not going to do an interventional trial with that kind of pile of data to say, oh, you're destined to do worse if you take cannabis. So let's do a trial and put people on immunotherapy on cannabis. That I wouldn't do that study based on even the little bit of data that's out there. So there's that. And I think the other small piece is there's a lot of our drug development is on targeted therapy. So these are going after a molecular alteration And most of those drugs are oral drugs that you take every day. They might have some liver metabolism, P450 kind of metabolism. And I think cannabis, we got to be careful there too. And we need to make sure that those drugs and agents are not going to be impacted negatively by the use of cannabis.
Yeah, important points. One is, evaluating potential, harms and risks, which is a big part of research. And, the thing, speaking of real world evidence and kind of straddling a couple states here, I think that's one of the things that makes Minnesota a little bit more ideal for research, because one of the issues we come up against in real world evidence in some of the states where we're looking at 1,000 plus SKUs and they're being launched faster than sometimes you can keep up with. It's very hard to distill that. And I think for a long time, there's been the hope of regression analyses or others identifying to the terpenoid level what might benefit a specific patient, but it becomes very complex and challenging when so many products are in the market and it's such a complex plant. Maybe a little bit of a leading question, but prior training in medical cannabis from your medical school days or other, you want to comment on that, Dr. Zylla? And you spoke a little bit to some resources that you use, but what did you have to do as a physician to bring yourself up to speed with cannabis, and was that a challenge?
Yeah, I mean, it is a challenge. And to answer your question, none. There was no training in medical school residency fellowship about cannabis. It really didn't kind of hit my radar until 2015. I also will add, I do not have any personal experience with cannabis. I've never used the product, so I feel like I don't know what I'm talking about, obviously. But anyway, I think it's just, I tried to find, where did I find, valuable references and resources. I think like anything in research and practice too, with some of these novel fields, I think you got to connect with the right people, the thought leaders, people doing that work. There's actually some good things happening in the cancer space. I don't think it was 20, I don't know, the COVID years blend together for me, but I think it was end of 2020. The NCI put on a very, very good workshop. I should have referenced that here, because I think all those talks and articles and presentations are now available. They put on a conference called Cannabis and the Cancer Setting, or something like that. I can't remember what it's called, but it was really, really good. And again, they brought in all the experts that have published good things. So I think there's more and more, certainly in the last even couple of years, there's some really good resources out there. I think the question is, where are we at in the much earlier side of things with, medical education or residency training in family practice or internal medicine, or fields where there may be, people coming and talking and asking you about this? Because again, I think patients are looking to us, their medical providers, to say, what do you know about this? Is this something I should think about? Where could it help me? And maybe we don't have good randomized trial data, but I think you can still have an honest discussion with your patient and say, yeah, I think it's, I've had a lot of patients use it. They get some benefit here and there. The other thing, I think it's a pretty safe product. Here are some of the issues, or at least as a provider, be able to point the direct patient in the right direction, to get high level quality information. I do worry still about the things that you find on the internet and, some of the bogus that's out there. So.
Yeah, something we certainly discussed in the past. And, I give every year a lecture to my residency in New York City, and it's kind of speaks to not only the challenge with research, but even the residents aren't really allowed to speak much about cannabis because the federal dollars received by the residency. And it still is that disconnect that, many patients come to us for these answers and we can't answer in some circumstances, which is still too bad. One question, I think we got enough time for just a couple more questions. One is, kind of this divide between synthetic cannabinoids and phytocannabinoids. And obviously there's this idea of entourage and kind of the question, do you see a potential difference between synthetic cannabinoids and phytocannabinoids? Are those plant derived? Any thoughts on a potential difference or how that might impact a patient or the idea of entourage?
Yeah, I don't have a lot of experience with those products. We've used dronabinol, periodically with our patients. I think it's not very well tolerated. I think that higher THC dose without some CBD sort of balancing it. My understanding is that entourage effect kind of helps to make that THC better tolerated. And I guess I've seen that in just the patients who are using cannabis, right? I mean, they just seem to tolerate plant or extraction brought cannabis better than anything like Marinol. So I did have one patient just the other week that we were kind of strategizing, like, well, what if this patient actually wasn't a Minnesota resident, couldn't get into the program, but was looking to get something with THC. And I said, well, what if you used a Marinol or dronabinol product, but we balanced it with a over-the-counter whole plant, whole spectrum CBD product? Like, would that kind of, make it kind of whole? And it seemed like it might work. Well, I don't know if that's what my nurse practitioner decided to do or try, but it kind of is intriguing. So I guess to answer the question, I don't know that I would go to the synthetics just because, well, A, they're still super expensive, although insurance may cover them. I just think the tolerability isn't necessarily there.
Great. And kind of to wrap up, how do you envision the future of medical cannabis in cancer care? What hopes and what do you see in terms of a vision for the future, Dr. Zylla?
Yeah, I mean, I think either they're barriers or they're opportunities. I'm not sure which one I would say, but I think, three that I kind of came up with, they all start with awareness. Again, I've talked about, I think patients and providers need to be willing to sit down and kind of discuss the role that cannabis might have in a care plan. Thankfully, I think that stigma is becoming less and less. I think patients I've seen certainly over the years are definitely willing to come ask me. Now, maybe it's because they know I have an interest in cannabis, but still, I mean, they're bringing it up to me. Whereas I think before, again, 20-30% of patients are using it. We don't know which 20% that is because they don't tell us. So I think we have to be more open and aware. And I think providers, even if you're not a big proponent of it, I think you owe it to your patient to just make sure they're aware that they could potentially be eligible or have access to these products and find the right person to guide them. So awareness is one, I think, is still out there. I guess I would say advice, again, kind of speaking to that too, that the providers, I think we have to get to a point where clinicians at least have some bare medical knowledge about the field that can say to their patients, yep, I'll certify you. I don't maybe know as much about dosing and symptom management and things like that, but I think it's pretty safe. And, and I'll get you to the right people who can help you with that. That's, I think, what patients are looking for. They're looking for guidance and approval to kind of go forward. And then the third big one, which we touched on a little bit, is affordability. And this drug is still far too expensive. Obviously, insurance does not cover it. We have I think I mentioned before, we have an abstract we just submitted to ASCO, which is our American Society for Clinical Oncology. The annual meeting's in June. And we summarize some of this large data survey that we are getting in Minnesota. And I think in that survey, it was predominantly, these are white, college educated. I think household incomes, most of them were over $100,000. Most of the patients reported they were spending between $200 and $300 a month for it. And that's just not doable for a large chunk of the population. And I think we have to figure out ways to lower the prices. I think insurance coverage would help. I don't know if that will ever come. But I think that affordability is a big barrier still in terms of getting this product to patients, and thus helping us get data to do research, right? If we can't get it in the hands of patients and actually have them use it, we're going to have less and less data to look at. So affordability is a big one still, I think.
Absolutely. Couldn't echo that enough. It's a bit of a catch-22 that, the challenge with research might be what pushes the needle, that research for insurance coverage. And so it's that catch-22 between the challenges of doing research and that need for affordability with cannabis. Want to just do one last plug. I put a little information on our upcoming free CME event, which will be April 7th and 8th in Minnesota. Just a fantastic lineup, incredible lectures there. Very excited for that. Dr. Zylla, just want to thank you for your time and your expertise and your dedication to your patients and getting better answers for medical cannabis. This was incredibly informative and excited for all the work to come. There's again contact information for Dr. Zylla and his crew there If you want to reach out, I want to thank everyone for attending tonight and the great questions and interactions. We hope to continue to do this in the future. I think, as we're all aware, education related to medical cannabis is lacking, and sharing the expertise like Dr. Zylla has. So thank you all for attending. Dr. Zylla, thank you for your lecture and participating, and we hope to see everyone soon.
Great. Thank you, everybody.
Have a good night.